I'm really excited to talk to you about this topic today. I am a general otolaryngologist at Ohio State. I have a subspecialty interest in otolaryngology allergy. I also have a main focus in quality and patient safety. So my role at the medical center stands beyond the department. I'm also the upcoming chief of staff-elect, or chief of staff for the medical center. So I really try to drive a lot of the initiatives as it relates to physicians to just make sure we're keeping our interests in mind. So with this talk, I'm not going to serve as an economist. I don't really look at numbers. I do read and try to follow some of the trends, hence my interest in some of the public health literature. And I'm not a fortune teller. So really, once again, I'm just interpreting the trends for you to try to give you an idea of where it looks, where the future looks for general otolaryngology. I have no disclosures. So before I really dive in, what I'll try to do is give you a little background perspective, like why are we talking about this future of otolaryngology, general otolaryngology, and talk to you about healthcare payment reform and how that's driving some of the trends that we're seeing. Also talk a little bit about some of the workforce challenges, reimbursement issues that we're having, and how a lot of these trends are shaping what we see today in otolaryngology. And then lastly, I'll go over some of the methods in which we're trying to counter some of the challenges that we're facing within our practices. So first, I just want to get an idea of who we have in the audience. So just by raise of hand, how many of you are just general otolaryngologists?
Okay, and general otolaryngologist that has maybe a subspecialty interest, sleep, allergy, so just two, and then the Rob. Okay, and then what about fellowship trained physicians? Okay, and residents, fellows. Okay, all right, great. Next, how many are in academic practices in the audience? Okay, what about private practice solo? What about a group? Only 3 in a group? Okay. And then what about a multi-specialty group like pulmonology, you have allergy, you have different specialties in that group? No one? And what about hospital-based? One hospital? Okay. And lastly, just years of practice, less than 5 years. 2, 5 to 10, 11 to 20. We have a very mature audience, I see. Okay, great. Then greater than 20. Wow. Okay, great. So many of you are going to be familiar with some of the historical perspective that I provide, but for those of you that aren't, then you'll get that too. So let's dive into healthcare reform. So traditionally, we've operated under this fee-for-service model. And so what that means is you come in, I provide a good or service for you, and then I get paid. Prior to 2017, about 95% of our payment was through this type of model, fee-for-service. Now we're probably delving more into 75%. One survey looked at how physicians felt about this, and still 70% or so, 70, 73, feel like, no, I really like this fee-for-service model. When you look at some of the pros of this model, the idea is that, hey, it does encourage the delivery of care. You need something that I can provide, and I will receive payment for it. It can be flexible, it adapts to different organizational structures, and it holds the person providing the service accountable because you don't get paid unless you provide the service. However, some of the cons for this service is that it doesn't promote efficiency, it doesn't prevent unnecessary care, and it limits the ability for you to receive that payment to a face-to-face visit. You have to encounter the patient in order to receive the payment. Some economists like to think that we're at this flat of the curve phase where the red line is. And what this means is you're getting very minimal improvement in your output, that health care, the improvement in health outcomes, despite the monies and the efforts that we're putting into health care. So this is driving kind of what kind of changes do we need to make within healthcare to improve our outcomes despite all of the input of healthcare. You probably already know this as well. When you think about the US, we're an outlier. Across the world, many countries, their healthcare spending is increasing. It's just that for the US, our healthcare spending is increasing tremendously differently. It's at rates that are much higher than other countries, so that currently we're at about $10,000 of health spending per capita. And despite all of this money that we're putting into healthcare, we're only seeing very minimal kind of improvements in the outcomes. We're not seeing these tremendous improvements in outcomes, and they don't compare to other countries who put in less dollars and have better outcomes. And this outcome is life expectancy. So this led to the IHI Berwick principle of triple aim. So how do we change this? What do? We focus on cost. We focus on patient experience or quality, and we start to focus a little bit more on the population, the health of the population. And this led to those goals of Affordable Care Act, where they want to increase access, quality, reduce costs. And how they do that? Universal health care and tons of reforms. And one of these reforms was payment reform. How do we increase quality and decrease costs, bring value to the services that we provide? So we're going to focus more on the payment reform aspect of this. And there are many alternative payment models. They can be pay for performance. Hey, there's a quality metric, you meet it, you get paid a certain amount for that. Bundle payments, where it says, hey, I will give you amount of money for this service that you provide, and it will encompass everything, the therapy, the complications, but this is the money you get for that. There's capitation. You're taking care of a certain population of people, and I'm going to give you a lump sum of money to take care of this population of people, and it's up to you to figure out how you take care of them with this lump sum of money. Patient-centered medical homes really doesn't apply to us. It's a primary care philosophy. And then accountable care organizations. How we're joining with hospitals to contract with insurers to provide for patients. And the whole idea here is, how are we moving from this fee-for-service model, which is more of a category 1 in this right picture with the big orange circle. We want to move, or the reforms say they want to move us from this fee-for-service model all the way to a category 4, where our payments are primarily population-based. Right now, we're probably delving into more of this category 3, where we're still under this fee-for-service model, but they're trying to institute some of these alternative payment models, ways to pay us based on quality and how we deliver this care efficiently. I like this picture on the left. I took it for some Arizona health system, but I like it because it's just showing this trend. As you go from a fee-for-service model all the way up to some of these accountable care programs, what you're doing is, yes, you're integrating and increasing accountability for the hospital or the provider. And with that increased integration and accountability on the hospital or the provider, us, there's increasing financial risk. And it's that increasing financial risk that has become the new burden for the physician. When you look at the landscape currently, most of these alternative payment models are accountable care organizations and bundled payments. So let's talk a little bit about reform in the physician. How does it impact our practice? Well, first, we were required to get the EHR, so the electronic medical record. The idea was to improve access to care. So you were seeing more insured patients and hopefully more patients. We now have these value-based payment models to pay us for good quality and low costs and trying to shift us from this fee-for-service. There was Medicaid expansion in certain states. And with this Medicaid expansion came all these very type of insurance products that really didn't necessarily pay us more. There were higher deductible plans, so now patients are left to think, well, I don't know if I can quite afford that right now. Maybe we should wait till the end of the year. So you enter into challenges of whether patients wanted to receive care. And then rising penalties and reduction in reimbursement. When you look at the Medicare fee schedule as it relates to inflation, inflation's in green and the fee schedule is in orange. When you look at that from 2006 to 2017, you see that the increase in payment to providers is not following the line of inflation, and it really hasn't changed. It's almost pretty flat, actually, despite inflation rising very steeply. And due to the current climate, I thought I would add this slide in, and it's trying to compare this Medicare for all philosophy versus where we are today. And if you guys don't know, Bernie Sanders is a huge proponent of this Medicare for All Act. And so if you just focus your attention on the middle column here, essentially what it's saying is for private health insurance, we expect that to go down because with the Medicare for All payments to providers or payments that you get from private payers to providers will go down by about 40%. And then Medicare stays the same because it's a Medicare for All product. And those that are currently on Medicaid, that will go up. Your provider payments will go up because, as we all know, we don't get paid as much for our Medicaid patients. But all these patients will then be shifted to Medicare. So you'll see the amount you get for them increase. And then other products are all pretty much aligned with what we do now with Medicare. If we institute that, there would be a 9% reduction in payments to providers. The Bernie plus 11% is basically saying, okay, with this Medicare for All, we also anticipate an increase by 11% of more insured people. And with that more insured, you see that, okay, it's back to like almost zero, no significant difference than where we are now, where the projections are. Now, this is just for physician and hospital payments only, but when you look at the plan and its anticipated benefit, it includes all payments that we provide to all types of providers, and they're estimating about a 5 to 10% reduction in payments to providers and hospitals. I pulled this to just show how Medicare physician charges to Medicare payment ratio aligns, and basically this says, I bill this amount, and how much does Medicare pay me? And for otolaryngology, it is about, it's 2.4. We bill 2.4 times that of what Medicare will actually pay us. In Ohio, it's about 2.5. Nationally, it's about 2.5. I looked up yours, it's about 2.0. So you bill 2 times that what Medicare will actually pay you. So I thought I would pull my own data. And so basically this side here, the top 2 are my new patient codes, 99203 and 99204 codes. And you can see that I billed $230 and $350, but what I actually got was $74 and $107. And for the established visits, 99213 and 99214, I did, you see, $157 and $230, and I got $50 and $76. And then to the far right are my nasal endoscopes, flexible endoscope, and wax at the bottom. Any general otolaryngology knows that good old wax. So $690, I got $150. $380, I got $81 for a flexible scope. 3157. 3157. And then for wax, that's right. How do you, yeah. $33. Okay. And so you can see how, and this is about 2.5 times less than what I actually billed for. So how does this healthcare reform actually impact you as the physician, your satisfaction? Well, you're now spending more hours on the computer, or what I call busy work, less patient interaction because you're trying to complete the charts. A lot of us are trying to figure out ways that we can counter this reduced revenue by doing other things like longer practice hours to increase that volume and access. We're diversifying our skill set. And we're just feeling like our financials still aren't meeting our expectations. We're now focusing more on these quality metrics and less about kind of just how we're caring for our patients. And then of course, a lot of us are kind of falling into this category of burnout because of all of the stressors related to running your practice. This is an interesting survey done by CompHealth, and if you don't know, CompHealth is like a big locums tenens organization, and essentially they were surveying people that came to their firm that were either leaving private practice, in transition, and they wanted to determine why you're doing this and what's your opinion of the Affordable Care Act. And they found that basically 50% viewed the Affordable Care Act as unfavorable. So in this audience, I'm going to just do very favorable and unfavorable. So how many of you actually think that since the implementation of the Affordable Care Act that you found it to be favorable for your practice, just by a show of hands? Okay. And how many of you just feel like it's very unfavorable? Okay, and then I'm just going to assume everyone else is somewhere in the middle. Okay, well, when they look at the data here from these groups of physicians that were transitioning or leaving their practice, all of them agreed that, hey, the Affordable Care Act has definitely increased my access. Access has improved, but none of the other metrics have really improved. There's been no cost improvement, there's been no quality improvement, my salary hasn't improved. Nothing else has improved as a result of the Affordable Care Act, leading many of these physicians to locum tenens, leaving their practices. So I posed this question to a group of people, asking them just how have you solved the problem of declining reimbursements and healthcare reform? So many people are seeing more patients, some are hiring physician extenders, others are aligning with hospitals. Some have just restricted acceptance of certain insurance plans, and others are really thinking of other alternative ways to gain revenue. So let's focus on the state of head and neck oncology. So our academy put out this information that basically said that still about 63% back in 2017 are in private practice ENT specialty groups. 63%. And then when you look at the distribution of the different specialties, about 57% still general otolaryngologists. So most of our members within our academy still general otolaryngologists practicing in these private practice group settings. But then when we look at this in comparison to some of the trends that we're seeing amongst our residents, it looks a little different. And so this is a study that looked at some survey data. It was published in 2013, and basically it asked the residents, what is your goal for graduation? Are you going to go into fellowship or no? And the trend over time has been anywhere between 60 and 70% of these individuals saying that they are seeking fellowship training. When you look at the various fellowships that they are seeking, you'll find that pediatrics, facial plastics, and rhinology at the time of this study were the leading fellowships that the residents were seeking.
Another study was done in 2016, same situation, and once again, 68% of these individuals said that they were seeking fellowship training. So this became very concerning because now you have about almost 70% of residents thinking, I want to do fellowship. So the question remains, are we training too many subspecialists? So by show of hands, how many think we're training too many subspecialists? Okay. Anybody that raised their hand that was actually a specialist? Okay. So let's look at the history of fellowships. So in the 1960s, fewer than 10 fellowship programs existed, compared to about 190 in 2013, and this number is much higher now. In the 1990s, 25% of residents pursued fellowship compared to that about 70% now. When you look at those that graduate from fellowship, 53% go into practice at academic settings. 94% of non-fellowship trained individuals go into private practice. So why general otolaryngology? Well, for the reasons why most of us even like otolaryngology in the first place. It provides this wide breadth of training and ability to interact with patients on many levels during very various procedures. It provides a very comprehensive type of care. Some may have an interest in certain patient populations. There's this idea that you don't delay the gratification of earning an income. Like you've done all of this training and you're just ready to gain income and reduce your debt load. And it's just job satisfaction. I often am asked why or how can you be a general otolaryngologist in an academic setting and why? And it varies from setting to setting. But for me, I found it very important to kind of pay it forward to the residents. I feel like on some level there's this loss of training to this comprehensive care, so it's very important for me to have a role in their training as it relates to that, maintaining that level of competency. Some also feel that academic institutions hire general otolaryngologists to just improve the referral base for the subspecialists. And this definitely does exist in many forms across various institutions. And I think it's up to the individual who does go into an academic practice to kind of set the standard on what they would like to, how they would like to shape their practice. Supporting the expansion of hospitals. So I know in my own personal institution, we're doing outreach to various suburban areas to try to increase that access and prevent patients from having to come down to the main campus. And so we're putting general otolaryngologists in these facilities to have captured these patients. And then, of course, leadership roles. Many feel that you can't be a leader within our academy or in any organization without being affiliated with an academic institution. So I posed this question as well to a group about why they feel people, or how do they view the role of general otolaryngologists in academic medicine. We don't really have to go with that for the sake of time. So then why fellowship? So a lot of people go into fellowship for a marketing advantage. So if you can go into a community where there's predominantly general otolaryngologists and say, hey, I am the sinus specialist. I'm the ear specialist. It gives you a marketing advantage. Once again, they plan for academic practice and leadership roles, so they do fellowship. It's kind of thought this is the trajectory that you should take. To gain a competitive edge in places where there are limited jobs. So in very dense places where there's not a lot of job opportunities, the thought is the more training, the better you can market yourself within that community. Some feel that, okay, I'm lacking in a certain experience from residency, and I feel like I need fellowship to kind of supplement this. I want to reach that mastery level. Job satisfaction, job security, and then lastly, is there a residency expectation that you're in my residency, I expect you to go into fellowship, and I want you to go into academics. And there are programs that are shaped in this way. I wanted to speak a little bit to the leadership aspect of this, just because this data from 2016 just shows what some of the breakdown of departments as far as it relates to leadership roles and who's holding them. And as far as chairs go, at this time, 37% were not fellowship trained, which I found very interesting and kind of counters that philosophy or that thought. Vice chairs, same thing. Most not fellowship trained. For program directors, it varied. There is more of the head and neck fellowship trained individuals holding these program director positions, followed by otology and general otolaryngology. So it kind of counters this idea that, hey, I need to do a fellowship to obtain some leadership roles. It's not necessary, but you can see that if you're a head and neck oncologist and an otologist, you kind of have a leg up on some of the others. So are general otolaryngologists becoming extinct? I don't think so. I don't think it's going to happen, right? We have a need for general otolaryngologists. We're not going to fall to the wayside. I think how we interface with our subspecialists, the needs of our community, the demands, just dictates how we practice medicine in this age of reform. Which basically means, okay, I'm a general otolaryngologist, but I also do these things. Or I am a specialty trained otolaryngologist, but I also do comprehensive care. So that everyone pretty much can feel the needs and the demands of the patient.
Also, this is just showing kind of the range in which that shortage for physicians in general will be, anywhere from 40,000 to a little over 100,000 physician shortage. And this graph is just showing that, hey, as people age, their requirements, their need for surgical specialty increases. So we don't need to be decreasing our surgical workforce. We actually need to be increasing it because this aging population is increasing. This is an interesting graph, and it's kind of busy, but we're just focusing down. Oh, you can't see that. We're just focusing here. And basically what this is saying is that at 2 years, the red, people are going to retire 2 years early in surgical specialty. We're kind of status quo as it relates to people staying in or the GME expansion, not very much. And then you have some that are also going to retire 2 years earlier or 2 years later, okay? So mostly there's not a lot of growth. Just as many people are leaving as there are staying. So it's staying very static. So what I did here was try to put together some of the data and compare otolaryngology residency programs to other programs and the type of growth we're seeing. How are we increasing our workforce to deal with these demands? And really, we're not growing very fast either. So if you look at otolaryngology from 2010, and then the data was recaptured at 2017, and now they follow it yearly, so 2018. And you can see that there is just not very much difference there between the years. General surgery is growing at a rate that's much more significant than ours. Plastic surgery had a significant rate of growth in 2017, but now it's kind of steady. But I guess the point being here, we're not changing very much as a specialty to meet some of these demands, and so that means that if we're not growing our workforce, those demands come to us, the individual who is within the workforce. But why are surgeons leaving? If we know that the patient volume would be there and we'll be able to see more patients, potentially make more revenue, why are we leaving? Well, retirement, as we already talked about. Financial losses. You can't make enough money to run your private practice, cover your debt load, student loans. You just can't deal with the financial losses. There's this notion of the loss of nobility and demoralization of the physician amidst this healthcare reform. Somehow the physician no longer holds this noble position in the community. This decreased emphasis on patient care. So now we have this love-hate relationship with seeing patients. Like, I really love taking care of patients, but gee, I gotta see at least 60, 80 a week to even break even. I can't spend as much time with you as I would like because, hey, I gotta see 45 to 50 patients today, you know? So there's this tug that occurs, this loss of autonomy. As we're in this age where government dictates to us what's the guideline, what's the protocol, how many of us sit on phone talking to insurance companies as to why we're ordering this medication, why do we need this imaging study? So it's other people that are dictating to us what's appropriate for care. The electronic health record, obviously, and adapting this into your practice, and then overall, with all of these things, just the burnout. There was a very interesting article that it was a commentary in Cato Institute, and the guy entitled the article, "How Government Killed the Medical Profession." And I love the article because he takes you through time and how it started with just these real subtle changes. And he says in the 1980s, it started with just CPT and ICD codes. And we were told, these are price control measures so that the procedure you do or the office visit, the time you spend with that patient, you make sure you get paid for that time and that procedure. And it was a very subtle intervention into our practice that started to dictate changes from there. Prior to people having the luxury of medical insurance, a lot of people just pay out of pocket for health care. So there was a transaction between the physician and the patient. Hey, give me your money and I'll do this service. Now we have more third-party interveners, and they get to dictate to us, well, I don't know if I want to pay for that. And so they set guidelines and protocols, and we have to jump through the hoops to get things paid. And then in the 2009, you had this intervention of, hey, everyone needs the EHR. You got to have it by 2014. And with this, it put great financial strain on practices. They couldn't afford to implement the EMR, or they just couldn't figure out how to adapt it into their practices. And then post-ACA, we're dealing with a lot of these cost reduction quality measures, and we have to kind of, I don't know, I feel like I call it the stepchild effect, but somehow the physician is viewed as the bad guy, and that we need these type of regulations to be kind of integrity, to demonstrate the integrity that we previously had, or we were thought to, demonstrate. So somehow I think a few bad apples have made it kind of worse for all of us, because I don't really think that the average physician is operating or going rogue, basically. So back to the future of otolaryngology. So what is the future? When we take all of this information and put it together, where do we see ourselves amid this reform landscape? So the extinction of the solo or the small practice, that seems very possible, probable actually, if more requirements, more performance measures, you have to meet these metrics in order to be paid effectively. So you may find definitely these smaller practices aligning with groups or hospitals to stay viable. Greater utilization of physician extenders to meet those patient demands and to serve as a means to increase your revenue. A lot of physicians are developing ancillary revenue. And so in my state, we have an otolaryngology practice that has its own surgery center. And this has been a very viable source of revenue, and I'd have to say most of their revenue probably comes from the surgery center. Our orthopedic colleagues have been very adept at making surgery centers their primary source of income to deal with some of these challenges. In-office CT, anyone in here have in-office CT in their practices? You can't have it? Really? Wow. You need a certificate? So I'm in an academic institution, and we have an in-office CT within our practice. And the big private practice group has an in-office CT as well as a way to generate extra revenue. And then obviously other things like hearing aids, et cetera. Are we gonna start looking at different practice settings? Like, not everyone has to come to the office. Let me figure out another way that I can have a virtual visit with you and generate income that way. So a lot of physicians are looking at telemedicine as a way to interact with patients without actually having to go somewhere. E-consults, we're starting that at our institution. Anyone does e-consults here? Yeah. So reimbursement is the issue, right? We're trying to figure out just how well these things will be reimbursed. But it's another way to kind of deal with patient care quickly without the patient having to actually come to the office. So we're going to be leveraging technology, basically. Will the general otolaryngologist be marginalized in areas where other people don't want to go? And that is the question. If we're going to have all of these fellowship-trained people going to these academic centers, will we find general otolaryngologists practicing in rural settings or in more underserved areas? I don't know if I really align with this particular prediction, but I will say a lot of my residents who are going into general otolaryngology are looking at practices where, you know, they're in one of the smaller towns 2 hours outside of Columbus, Ohio, and they get these large salaries, like $400,000 salaries to come work there for 2 years. Obviously, they get that, and then it's all on them. But nonetheless, they attract these general otolaryngologists to the area. So we start to see trends in this direction. We talked a little bit about how there's this fear of saturation amongst people who train as fellows. But the idea here is I think there will be more of a trend as these access needs need to be met, that subspecialty trained physicians will start to be more comprehensive in their care. I know the otologists in my department do not want to see anything that's not an ear. They will not. But I think that day and age is over. You're going to have to expand your practice because you may find that even your revenue suffers if you don't. And then the loss of the workforce we already talked about. And then there's this idea of cash-only practices, of which some surgeons are now entertaining. I don't want to deal with insurance companies anymore. I just want cash for the services I provide. So to just wrap up with some of these key components, why are APPs important to our practices? Why do we want them? Well, they can meet some of the demand and take some of the pressures off of us as physicians. They can help triage those non-surgical patients or those low-revenue patients so we don't have to see them. They can increase patient education and hence patient satisfaction, and then with increased patient satisfaction, your quality metrics go up, which increase your reimbursement. So that's a benefit. But I think we need to be very cautious when we are training APPs to do what we do. Are we retraining our replacements? Are we devaluing the medical doctor? And I bring this up, and I think Rob talked about it a bit, but the AMA is very focused on this kind of Transparency Act, this advertising initiative to make sure that there's not this false advertisement that occurs amongst physician assistants and nurse practitioners. And I pulled this was in the U.S. News and World Report, advertising for physician assistants, and it's saying, hey, if you haven't seen a PA, you will soon, and they undergo intensive training similar to your doctor, and kind of promoting this idea that they're somehow equivalent, and they're not. There's also an ad out there that says it's the cheaper doctor. It's the cheaper way to receive health care. And when you look at statistics, this is from Consumer Reports, physician assistants are now increased by 107%. I looked at APPs as it relates to surgical data, and they compared this from 2008 to 2016 and found that there is like a 16% increase in APPs within surgical specialties. The only surgical specialty that really didn't have an increase was ophthalmology. And most of these APPs were physician assistants. This is real. I serve as the co-chair of the College of Medicine admissions committee for my for our college, and I go out to talk to these undergraduate students about medical school, and invariably there are at least 3 kids in the audience that says, hey, I'm having a trouble deciding between becoming a PA and an MD, and I'm like, I didn't even know that was a concern. And now it's more and more prevalent amongst the younger generation that they think that it is the cheaper alternative to becoming a physician. The burnout problem is real. Difficult work-life balance, younger physicians and females, and the female is more subject to the burnout because they complain that they don't have the spousal support they need. They're the ones primarily taking care of children, and they're having to juggle a lot more. But this lists all of the reasons why we're dealing with burnout, and a lot of them are just challenges dealing with practice dynamics. And then lastly, this cash-only philosophy. So we already see it with like LASIK surgery. Cosmetic surgery has been delving into this realm for a while, but the question is, could we take some of our other procedures that we do and say, hey, this is the cost for that? And I read an article from a gynecologist who says they charge a few thousand for a hysterectomy. They get $500. So now at their surgery center, he charges $1,000 for the hysterectomy, and he's getting 2 times as much as insurance would have paid him. And patients are willing to do that, but he has his own surgery center, and that's the key. Because he's able to put together a payment package that includes anesthesia as well as surgeon's fees, and they can make out that way. So it's a very hard concept if you don't control all the components as it relates to the surgery, because there are other fees involved. And so in conclusion, healthcare reforms are imminent, and they are impacting our lives daily. And as otolaryngologists, particularly general otolaryngologists, who are focusing more on the medicine side of ENT, more so than some of our counterparts, we must strategize to figure out ways how we can leverage declining revenue and patient demands. And we must be wise about the approaches that we take so that we're not developing a system that becomes this slippery slope when we look back and say, ooh, why did we do that? And kind of devalue who we are as physicians. And that's it. Any questions?
Just a question about being a general otolaryngologist at an academic center like Ohio State. At least my perception is, I always wondered if I would have stayed where I trained, that the advantage is that, you know, I can do a stapes and I can do a neck dissection, but the otologist there can't do a neck dissection and the head neck guy can't do a stapes. But I know that I can do either one as well as the otologist or the head neck person. So there's an advantage to being sort of cross-trained and doing everything, but doing nothing as well as the specialist that happens to be in the same department. I mean, I guess, is that
Is it a concern we have?
No, actually. I think it's no different than if you just look at people within the same specialty. Some people are going to be able to do things better regardless, right? And you're speaking more to the volume. They see more of this, so they're probably more adept at this. But we don't have those in our practice, it's different. So I'll just tell you how we do it. We have a common call center, and our head and neck oncology division has their own call center. So any referrals that go into the James Cancer Hospital goes through that call center no matter what, and it gets filtered through the various departments. So then you've got this general division who's consisting of otology, rhinology, laryngology, facial plastics, everyone. And so I'll use the example, I gave this example earlier of chronic rhinosinusitis. All the generalists and the rhinologists do this. So we've set it up in such a way that it's an access issue. So if the rhinologists who are trained, they don't do anything else, if they're scheduling beyond 2 weeks, then that patient goes to one of the general otolaryngologists. It's an access issue. And so as far as volume, they're gonna get first dibs, but once their schedule fills up, our volume allows for us to see sinus cases as well. We also have a paradigm that the schedulers follow that tells them these if-then, these algorithms that tell them these if-then scenarios, and what complaints will go where. So it kind of filters it. Same thing for ear surgery, access issue. If you can't get in, well, our otologists are even a little bit more picky. So they don't even want to see anyone who hasn't seen a general otolaryngologist. So there becomes this issue where those patients will get filtered to us first if they come in with a complaint of hearing loss, or if a general otolaryngologist out in the community must have seen them before the otologist will see them. But yet and still, if someone says they have hearing loss or what have you, it's about who can they see first. A lot of the otologists, though, like I said, they have limited their practice by they must have seen us first. So if I do stapes and I see that you have hearing loss and I feel comfortable doing stapes, I'm going to do your stapedectomy. You know, that's the otologist loss if they didn't want to see that patient. All direct referrals, though, to whomever go directly to you regardless. So it still is about you building your practice. So if I go out into the community and I talk to an endocrinologist and they send me all their thyroids because they really like me, then I get all their thyroids. See what I mean? So my practice is very similar to a private practice type of situation. And I just filter things that I don't want to do to the specialist or even to one of the other general otolaryngologists. Like, you want to see that? Yeah. The other thing is all of us have niches within the department. So mine is allergy as well as sialoendoscopy. And we have a sleep guy. And then our other general otolaryngologist is our director of trauma. And so we have little aspects within the practice as well that we oversee. So it works, but it depends on your leadership. So if your chairman or your leader doesn't value the role of the general otolaryngologist, then you end up getting just the scum, the things that the specialists don't want to see. So it has to be shaped in such a way that promotes the general otolaryngologist as well.
Is the model that Ohio State is the university branching out across the state trying to capture market share? And are they hiring general otolaryngologists to do that, or are they hiring or partnering with practices out in the community? It's an interesting thing that seems to happen with universities and big organizations, big health organizations, as they expand out and they start hiring general otolaryngologists within themselves. The general otolaryngologists in the community start to form their own little mini university type practices, hiring specialists, and it becomes this competition.
Yeah, so yes and no. Yes, Ohio State has suburban facilities. So we have a center facility that's our main campus, near main campus, and I happen to work in one of the suburban offices, which is about 15 minutes from the main campus. And then there's another office, we have an east and west office, and then a center office. And in the west office, there's also general otolaryngologist that goes there, but in both offices, there's otology. Laryngology goes to one of the other offices, so they still go out there, but they're primarily manned, especially my office, manned by a general otolaryngologist. I still come down to the main office once a week to see patients within that kind of facility, and I operate at the main campus, okay? Now, Ohio State is a little different in that they're just not going to be offices anymore. They're going to be ambulatory surgery centers combined with office buildings. So we're transforming all of these facilities into multi-specialty little mini groups. And so that you won't even have to go down to the main campus anymore. So specialists, general surgery, rhinology, what have you, any kind of surgical specialty would be located in this building, and you'll have your surgery center associated with your facility. So it's all in an effort to keep that access out in the suburbs. So you'll find that even the subspecialists are going out there as well, but they're primarily manned by the general otolaryngologist, and there's no competition there.
I just want to say to the residents here, I'm a subspecialist. I think general or comprehensive otolaryngology is alive and thriving. I think you can go into almost any community and find a good general otolaryngology practice. And what happens in real life is that people end up having a predilection. They kind of like dealing more with children. They like dealing more with nasal sinus condition. If you join a group, 4 or 5, 6 person group, someone there likes to do the stabies, but they're doing comprehensive otolaryngology. So for all of you residents, I believe that general otolaryngology is alive and thriving, and I can place a generalist almost any city in the United States. I don't think you need to be a specialist. That 70%, it would be interesting if you took away pediatrics versus every other specialty. Because pediatric otolaryngology is a specialty that's just quadruple.
Right.
So take away that, and then I think you'd see the number of subspecialists is not that different than what it used to be. Because pediatric otolaryngology, you know, in the old days, I'm an old guy, but it was airway. Other than airway or congenital malformation, the general otolaryngologist did the tonsils, the sinuses, head and neck masses were pediatric. So I don't want to discourage any of you residents that are here. I think there's great opportunities for you if you choose to do general otolaryngology.
I agree, as a general.
Well, of course, Dennis and I are good friends, but my name is Ed Jankowski. I've gone through that transition. I was a solo private practice in the metropolitan Detroit area. It's just very difficult for solo private practice to survive in any specialty, as you well know, with the ongoing trends. I enjoyed your talk greatly. I didn't learn much because I already knew all this stuff.
Sorry.
But that's okay. I'm living proof that it's happening. I had to change my whole venue after 26 years in private practice. It's not easy to do. But I had a godsend employment opportunity where I work now in a rural practice, small town practice in Branch County, in Coldwater. And I've been there 4.5 years and very, very pleased. I'm operating more now than I ever have. I'm not competing against a 10 million group or anything. And I'm the only guy from 3 counties for ENT. So I've got plenty of primary care referral sources. General ENT is doing well, and they will always need us. A subspecialist cannot survive in rural America. Okay. They have to be in a major metropolitan area or an academic center, and most academic centers are in big cities anyway, they'll have their own. So the danger is that if you localize it, you'll eventually have plenty of competition, of course, with all subspecialists. And I like that pointed out, after all, it's saturation. But I think general ENT will always be needed anywhere, even big cities, suburbia, and we just have to adapt to the changing conditions. And the burnout issue is real in all specialties. I don't care what academia, private practice, whatever. Obviously, primary care is also affected by this international trend. And to say to the young docs and the residents in this room, you're going to have to learn to be even more versatile than, say, your mentors were. But if you are versatile, then you'll do fine. You'll do very well. But make sure that you do not forget to live your lives. Okay? You have families, you have kids. Make sure you prioritize appropriately, because that, in the end, when you retire, those are the people that you really have to answer to. So don't forget that.
All right, thank you.